Welcome everyone. This video is about the changes to the incident definitions and GER guide that will go into effect on May 1st, 2022 for all providers of the CDD and DDAD waiver services. This presentation was created through the Quality Improvement Contract by Liberty Healthcare Corporation with cooperation from the Nebraska State Department of Health and Human Services Developmental Disabilities Division. This version of the video is created for DDAD and CDD providers. First, let's talk about why changes are being made to the incident reporting process. Centers for Medicaid Services requires the listed assurances from states. These assurances focus on demonstrating that state systems have designed and implemented an effective system for assuring waiver participant health and welfare. These are the assurances that require states to have a robust critical incident management process. In January of 2018, the Office of the Inspector General, in partnership with DHHS, Administration for Community Living, and the Office for Civil Rights, compiled a report to help improve the health, safety, and respect for the civil rights of individuals in group homes. This report provides model practices to CMS to increase compliance, oversight, and to help ensure better health and safety outcomes. The recommendations found in this report influence the changes you will see today. It is important through these changes that we remember that everyone involved in the support of people who utilize the CDD or DDAD waivers have essentially the same goal: to promote health, safety, and respect. Incident reporting is one piece of the puzzle we need in working toward increasing the attainment of individually defined outcomes for participants. First, we are going to go over the purpose of this training. Starting May 1st, 2022, incident definitions and the TheraP GER module will be updated. This video has been created to assist in the trainings of all providers, independent staff, and agency staff in the updates. Additional Q&A sessions to answer further questions will be available on Tuesdays at 11 a.m. and Thursdays at 4 p.m. We ask that you submit your questions ahead of time via the SurveyMonkey link. Purpose: intended for all providers of Medicaid home and community-based waiver services through the CDD and DDAD waivers. Outlines who is responsible for reporting incidents, provides timeline for required reporting, defines reportable incidents, describes how incident information should be entered into TheraP, only covers incidents that must be reported to the Division of Developmental Disabilities in TheraP via General Event Report. This guide does not give instructions for access or use of the GER module in TheraP. Further training on using TheraP and setting up access can be found through the TheraP homepage. Reportable incident definitions. DDD defines reportable incidents as any incident, injury, or illness in the following categories: allegation, suspicion, or actual events of abuse, neglect, or exploitation of a child or a vulnerable adult; change of condition or medical decline; communicable disease; death of a participant; emergency situations; falls with injury requiring more than first aid; incidents involving emergency personnel requiring emergent response; infestations; injuries of unknown origin raising suspicion; injury requiring medical or nursing interventions beyond first aid; medication errors; misconduct not involving law enforcement; missing persons; as needed psychotropic medication usage; property damage; suicide attempts; swallowing inedible items; unplanned hospital, emergency room, or urgent care visits; use of emergency safety interventions; use of restraint or prohibited practice; and vehicular accidents. A list of all notification levels, event types for entering into TheraP, and additional directions can be found in Appendix A of the GER guide. Medication errors have notification levels based on attributes of the event. For example, a medication error resulting and an immediate physician visit or hospitalization is considered a high notification, while an error of the 5 rights is considered a medium notification. It is important to understand that trending of incidents may lead to an escalated notification level in the future. Notification levels. Low-level incidents are not considered reportable. However, a GER is now required for these incidents to ensure thorough tracking and trending. Incidents that present a trend have the potential to be escalated to a higher reporting level. Providers may still use the low notification level to report items they wish to track or trend, but this is not a requirement. Medium-level incidents are the less critical incidents that were previously reported as a high GER. These incidents will be tracked and trended. Trends noted in the medium level may be escalated to the high level, requiring further follow-up. High-level incidents will be incidents involving death, abuse, neglect, or exploitation, prohibited practices, criminal charges, and medication errors, resulting in immediate physician or hospital intervention. Allegation or suspicion of abuse, neglect, or exploitation of a participant. Any allegation or suspicion of abuse, neglect, or exploitation committed by a provider, peer of the participant, family member, or anyone else in which the participant is a victim. Also used when the participant is the perpetrator against another participant and when the participant neglects him or herself. Abuse is defined as the willful infliction of injury, unreasonable confinement, intimidation, or punishment with resulting physical harm, pain, or mental anguish. Prior state only required reporting if an injury was noted. Abuse, neglect, and exploitation include but are not limited to physical abuse, verbal abuse, sexual abuse or exploitation, psychological abuse, neglect, or exploitation. All allegations will be reported regardless of the participant's history of fabricating stories. Participants with a history of fabrication have a higher likelihood of being a victim, due to the other's nature to not believe them. All allegations and suspicions require APS, CPS, and law enforcement notification. Behavioral incident. A participant displaying maladaptive behavior that impacts their ability to interact with others or be safe in the community or at home. This includes self-injurious behavior not meeting reportable injury definition. Only reportable when the behavior is not otherwise tracked elsewhere, such as a BSP, safety plan, or safety tally. If behavior events result in an injury requiring more than first aid, emergency safety intervention, or medical intervention, this incident will be reported in a different event type. Maladaptive means disruptive, disorganized, agitated, or aggressive behavior. This category should not be used to report non-compliance. Participants have the right to refuse. Refusals that result or have significant potential to result in adverse outcomes for the participants should be addressed by the ISP team to incorporate assessments, support, and training. Change of condition or medical decline. Any change in medical condition of sufficient severity to require assessment or treatment from a physician, regardless of whether medical attention was received. The provider must determine whether the severity of illness or change in condition meets the criteria based on whether an objectively reasonable person would seek assessment or treatment from a medical professional. You must always report aspiration, severe constipation or bowel obstruction, dehydration, seizure, sepsis, or actual or potential airway obstruction. Reports of aspiration, bowel obstruction, dehydration, and sepsis require a diagnosis from a physician. It is likely that this event type may also include other events, such as hospital. Seizures are reportable when it's the first time a participant is having a seizure. It is also reportable when the seizure lasts longer than 5 minutes, unless the participant's physician has set a different time frame to determine when a seizure is cause for concern, or a time frame cannot be established. Reporting is not required for illness or changing condition commonly treated with over-the-counter medication, which is minor in nature, when a participant is seen by a physician to get a prescription for over-the-counter medication, such as cold or allergy medication, routine or planned checkups, or follow-ups related to existing illnesses or chronic medical conditions. For example, a participant receives intermittent services. They take themselves to the doctor outside of services for a simple cold. The doctor tells them to take Tylenol cold and flu. This would not be considered a reportable incident. Communicable diseases. Participant who is diagnosed by a medical practitioner with an illness such as COVID-19, influenza, tuberculosis, etc. A communicable disease is an illness carried by microorganisms and transferred through people, animals, surfaces, food, or air. Although a cold or upper respiratory infection could be considered a communicable disease, this would not be considered reportable under this incident category. This event type requires a diagnosis from a physician. It may be likely that additional event is added to the GER when reporting this event type, such as hospital. This category will replace all previous reporting requirements for COVID-19. The death of a participant is considered a reportable incident regardless of the cause or location. Deaths must always be reported, and the GER does not substitute the need for a notice of death form. Deaths, although a reportable event, will be addressed through a mortality process separate from critical incidents management processes. Other events preceding or causing the death may be reviewed through the critical incident process. Emergency situations. Any injury caused by a fire, flood, tornado, severe weather, or other emergency or natural disaster, regardless of severity. Injuries caused during the event, for example, John fell while running to the shelter, are not reportable under this category. Only injuries received directly from the emergency, such as being struck by flying debris, are considered reportable. Injuries received during the disaster, but not directly related to it, may be reportable under another category. Any displacement of a participant from a site where DD services are usually provided when the displacement is caused by fire, flood, tornado, severe weather, or emergency or natural disaster for one full day, overnight, or longer. This does not include if the participant cannot go to the provider site due to weather conditions or other unsafe circumstances, but the site itself is not unsafe or damaged in any way. For example, if a participant is unable to go to the day site because of bad roads due to a blizzard, this would not be considered reportable. Falls with injury requiring more than first aid. When a participant comes to rest unintentionally on the ground or lower level, for any reason, and sustains an injury requiring more than first aid. Injuries are harm, pain, illness, impairment of physical function, or damage to body tissue. External forces or causes can include sources of trauma in which the skin is torn or punctured, or where blunt forces cause a bruise or fracture. External forces can also include strains or sprains, exposure to toxins or poisons, burns or frostbite, and can be accidental, caused by another person, or caused by the participant. Incidents involving emergency personnel requiring emergent response. Any event that results in the activation of law enforcement, ambulance services, fire department, or other emergency response departments. This category would be used for any of the following: police contact for questioning, welfare checks, or arrival during an EMS call when no criminal charges are brought against the participant, ambulance or EMS arrival regardless of transport, fire department arrival regardless of actual fire. This would also be utilized when the fire department is deployed for false alarms. Other response agencies may include hazmat teams in the event of a chemical or other hazardous spills. Infestations. Any incident in which a participant has the presence of insects or animals in a place, typically to cause damage or disease. Presence of an infestation may include bites or rashes caused by the infestation. It could also include other signs of infestation, such as live or dead parasites or parasite eggs, animal droppings, or evidence of a dwelling. This category does not include all insect or arachnid bites. Bites and stings during exposure to insects or arachnids in an outdoor environment, or due to contact with insects or arachnids that do not cause infestation are not reportable in this category. Injuries of unknown origin that raise suspicion of abuse, neglect, or exploitation. These may include injuries not observed that cannot be explained by the participant, injuries where explanation is inconsistent with the size, type, severity, location, or pattern, injuries not consistent with the participant's means of mobility, bruises in areas less likely to be accidentally bruised, such as the face, neck, back, abdomen, arms, buttocks, ears, or hands, multiple bruises in a unique form or cluster, injuries carrying a clear imprint of a hand or object, human bite marks not caused by self-injurious behavior, cuts or abrasions on areas typically covered by clothing, injuries to genitals or the anus with no related cause, patterns of similar injuries over time, or no cause determined. Injury requiring medical or nursing intervention above first aid. An injury of sufficient severity to require assessment or treatment from a physician, regardless of whether medical attention was actually sought or where medical attention was received. The following must always be reported: concussion, dislocation, fracture, poisoning, pressure sores and ulcers, and third-degree burns. The provider must assess whether the severity of injury meets this criteria based on whether an objectively reasonable person would seek assessment or treatment from a medical professional. Medication errors. Any preventable mistake in the administration of medication, treatment, or procedure with the potential to cause harm to a person. High. Physician intervention or a hospital visit are needed. Medium. Any type of error in the 5 rights. Low. Charting errors. Examples: administration of medication, treatment, or procedure in a manner inconsistent with prescribing physician instructions, failing to administer needed medication, treatments, or procedures, administration of an as-needed or over-the-counter medication causing an interaction with prescribed medications, or inaccurate or missed documentation. Misconduct not involving law enforcement. Any event that involves possible criminal activity where law enforcement is not involved. Examples include, but are not limited to, exposing oneself in public, possession of drug paraphernalia, cruelty towards animals. Providers must assess whether the severity of the event meets this criteria based on an objectively reasonable person not receiving DD services would potentially receive criminal charges. When in doubt, err on the side of caution and report the incident. This category is for incidents of lesser severity. If the provider witnesses or has reason to believe that a more serious crime is being committed, the provider should involve law enforcement. Incidents that would be potential felonies, such as sexual offenses, should always be reported to law enforcement. For participants that have a trend noted in this category, the ISP team should meet to develop a plan. For example, John Doe has exposed himself 3 times in public. The team knows that this is because he had to urinate. The team may meet to add additional supports in this area to help John understand community bathrooms, privacy, and other related issues. In another example, Jane Doe has a history of drug addiction, and this is the 3rd time her provider has found drug paraphernalia. Jane understands that this is illegal to have in her possession. The team meets with Jane's input and agrees that if further paraphernalia is found, the police will be called. This is documented in Jane's ISP. All team response to this should be individualized. Missing persons or AWOL. When a person is not at an area or location that they are expected to be at, or leaves the provider's presence or site, intentionally or unintentionally, and their whereabouts cannot be determined for 30 minutes, or the time frame set in their person-centered plan, alone time or supervision time. For this to be reportable, the participant's whereabouts must be unknown. When a participant leaves a provider location, but the provider follows them, this would not be reportable under this category. If a person requires constant supervision, on-site supervision, or one-on-one, then any time outside of this where the provider is not aware of their location would be considered reportable. As needed psychotropic medications. Any administration of a prescribed psychotropic medication on an as-needed basis used as a last resort method when all other behavioral interventions have been ineffective. Psychotropic medications act primarily on the brain, resulting in changes in perception, mood, consciousness, or behavior. If the administration of an as-needed psychotropic medication is not used as a last resort or is used for provider convenience, it will be reported under prohibited practice chemical restraint. For example, the participant becomes agitated. They have a safety plan in place with interventions to be used. When all of those interventions have been attempted in good faith and proven to be ineffective, or the severity of the incident does not allow them, then a psychotropic medication may be used. Property damage. Physical destruction or damage to items, furniture, or the physical structure of a building or damage to property of a total estimated value of $150 or more, inflicted by a participant regardless of the participant's ability to understand the value of the damage. This is only reportable if property damage is not tracked or addressed through other means, such as a behavior support plan. Reporting does not indicate that the participant will be required to pay for the damages, and repayment for damaged property must be reviewed by the ISP team and follow state guidelines. Suicide attempts. Any event in which the participant harms themselves with the intent and means to end their life. Self-harm attempts without the intent to kill oneself will not be reported under this category. The participant must have a clear intent and means. For example, if the participant says, "I'm going to shoot myself," however has no access to a gun, this would not be reportable. If a participant is cutting themselves with no intent of death, this would also not be reportable. All threats of suicide should be taken seriously regardless of their reportability. The team should consider and offer mental health and other services as appropriate in these circumstances. Swallowing inedible items. Any incident at which a participant swallows an item that is not fit or suitable for eating. Items include but are not limited to coins, batteries, plastic, and chemicals. This event may be tied to a pica diagnosis, but the participant does not have to have a pica diagnosis to use this category. The item must truly be considered inedible for this to be reported. For example, although many people may find the ingestion of dried nasal mucus to be disgusting, the ingestion of it is not considered to be inedible. Personal preference should not be used to determine if an item is inedible. Unplanned hospitalization, emergency room, or urgent care facility. When a participant is admitted to a hospital or is seen in an emergency room or urgent care for any medical or psychiatric reason, or admitted to a hospital and then transferred and admitted to another hospital, the second hospital admission does not need to be reported in an additional incident report. The transfer should be documented in the follow-up section of the original incident report. Reporting is not required if the participant is seen by a physician to get a prescription for over-the-counter medication, such as over-the-counter cold or allergy medication. Use of emergency safety interventions. Any use of physical contact that restricts or is meant to restrict the movement or normal functioning of a participant as an immediate response to an emergency safety situation. Use of emergency safety interventions is always reportable, regardless of whether it was an approved intervention in the participant's plan. There must be a need for an immediate emergency response for this category to be used, such as the participant is running into oncoming traffic, displaying behavior at such a severity that others or themselves are at an immediate risk, and other less restrictive interventions are unsuccessful or unable to be performed. Another example, John Doe has begun punching his peer in the face. Although he has other interventions such as planned ignoring, cooling off period, or coping skills, attempting to implement those interventions versus physical intervention would cause significantly more injury to the others involved. Physical intervention should be a last resort and not used for compliance or convenience. Use of restraint or prohibited practice. Reportable incident if any use of a prohibited practice. Prohibited practices are mechanical restraints, physical restraints except when used as an emergency safety intervention, chemical restraint, adversive stimuli, corporal punishment, discipline, seclusion, denial of basic needs, or implementation of an intervention by a participant. A definition of each prohibited practice can be found in Appendix B of the GER guide. Vehicle accident. Any vehicular accident that results in an adverse outcome to the participant or that involves media attention or criminal activity on behalf of the provider staff. A vehicle accident is defined as the unintended collision of one motor vehicle with another, a stationary object, or a person impacting a person receiving HCBS services. This could be as a result of either riding in a vehicle or being hit by a vehicle. Even if the participant is not injured, this would still be reportable if the provider is charged with criminal activity, such as drunk driving, or the accident results in media attention. Reporting and notification requirements. Reporting requirements are clearly defined in an easy-to-read table found in the GER guide. All high-level GERs require a verbal notification to the participant's service coordinator. This verbal notification must be made as soon as possible after the incident was observed or discovered. The provider should ensure safety of the participant and others prior to notifying the service coordinator. If you are unable to reach the service coordinator, you must leave a detailed voicemail. If you cannot leave a voicemail, you can follow up with the service coordinator via secure email or SCOM. SCOM would be the preferred method. Your detailed voicemail, email, or SCOM must include your name and who you work for, the name of the participant involved, the type of incident being reported, a brief summary of the incident, and a brief summary of what actions were taken to ensure safety. If you are unable to leave a voicemail, you may follow up with SCOM or secure email with the same information as above. Never text a service coordinator as it is not a secure form of communication. If a notification is delayed, you must document the reason in the GER. If the participant has a guardian with authority to know of the incident, the provider must notify the guardian within 24 hours of the verbal report to the service coordinator. If a person has more than one guardian, the provider must attempt to contact all appropriate guardians. If the provider cannot reach the guardian, a voicemail will suffice. This notification is not applicable when participants do not have a guardian. It is important for the provider to understand the scope of authority for the guardian. Not all guardians have legal ability to know this information. For example, if a person has a financial guardian, power of attorney, or payee, this person would not necessarily have the clearance to know of medical incidents. The preferred timeline for notification and GER is as soon as possible upon observing or discovering the incident. Verbal notification to the participant involved. This step is not applicable when the participant was present or aware of the incident. If the participant was not aware of the situation, the provider must notify them of the incident not more than 24 hours after the service coordinator notification. It is best to do this in person. The preferred timeline for the notification report is as soon as possible upon observing or discovering the incident. For all identified incidents in the GER guide, a written report is required. All GERs must be submitted into TheraP within 24 hours of the verbal report to the service coordinator and must be approved within 72 hours. It is best not to approve immediately after submission to ensure that any errors can be corrected prior to approval. What are the next steps in the process? Starting April 15, 2022, training will begin on the new definitions and GER guide. All DD providers in the state of Nebraska will begin reporting with the new definitions. During this time, the pilot process will enter Phase 1. During Phase 1, the providers will work on meeting key indicators for entering GERs correctly and thoroughly. When the key indicators have been met for Phase 1 for 30 days, training will begin on Phase 2. Phase 2 will incorporate the components of Phase 1 while adding in the requirement for remediation. The pilot participants will receive thorough training on the new requirements prior to going live with Phase 2. When the key indicators for Phase 2 are met, Phase 1 will roll out to the non-pilot participants in the state, while the pilot participants move on to Phase 3, which will include targeted analysis. More training will roll out for Phases 2 and 3 as we move forward in this process. Now that we have completed our overview of the new definitions and reporting guidelines, meetings will be scheduled for every Tuesday at 11 a.m. and Thursday at 4 p.m. These meetings will serve as a platform to answer further questions you may have after reviewing this training. We ask that you submit your questions ahead of time via the SurveyMonkey link so that we can organize the Q&A meetings in an efficient manner. There will be a separate Q&A meeting for the pilot participants and the overall Go Live providers. We look forward to implementing this new process in Nebraska and your input and assistance through the process. In the end, the quality of life for those who utilize waiver services will improve.